Hello everyone, in this video we're going to be looking at the glossopharyngeal and vagus nerves section of the course pack. This resource is brought to you by Scrubs, which is the Student Collaborative Resources for Understanding and Brody Success. My name is Bryce Pugh and I'm in the class of 2027. We'll start with the Scrubs mission statement. Scrubs is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody. Members of Scrubs participate in a variety of subcommittees working to create resources for students by students. The resource aims to offer unique perspectives from students that have walked in the same shoes, developing resources that we wish we'd been exposed to during our time in the course. The hope is that this organization will become a staple of the Brody student body, exemplifying the unique collaborative community that Brody offers. If this is a mission that aligns with your goals, and you have the desire to help those that will come behind you, as well as the goal to leave your mark on Brody as a whole, we invite you to join the team. A quick disclaimer, the resources that are included in this document are made by students and not the faculty. As such, there's a possibility for errors in our development, although this is mitigated via a team approach to development with multiple stages of vetting. If there's a contradiction with the coursework presented, always go by the course documents. Additionally, Scrubs aims to supply supplemental resources. However, these are in no way replacements to the instruction of the Brody faculty. Use these resources as a supplement, but not as your primary source for course material. Okay, so looking at the glossopharyngeal and vagus, they're both going to exit the brain off the medulla region, which we'll look at in the next slide. And it's going to come down through the jugular foramen. And you can see here, this is going to be right about this point of the skull, and it's going to come down. It's called the jugular foramen because this is also where internal jugular vein is exiting. And it's going to run down into the carotid sheath, or the vagus will run down into the carotid sheath with the jugular and carotid. And so we see it going through here. If we look at the inferior surface of the skull with the mandible removed, then you can see the jugular foramen right here from the outside. So this is if we just turn this over. And so this is definitely a foramen that would be worth finding on an actual skull, making sure you know what that looks like. Looking at a quick overview of the two nerves, cranial nerve 9, glossopharyngeal, is going to have motor and sensory components. We can see that over here with green indicating sensory and red indicating motor. Our parotid gland is going to be one of the primary motor innervations, which is going to give secretions of saliva, and then we're going to have half of our gag reflex motor innervation from glossopharyngeal. We're also going to have sensory innervation, which is taste and GSA for the posterior third of the tongue. Remember, we looked at the anterior 2/3. With the facial, we got posterior 1/3 with sensory. We also innervate some of our pharynx, and so we'll see some of the gag reflex coming from cranial nerve 9, like we talked about there. Cranial nerve 10, our vagus nerve, is going to innervate a ton of things. We can see this coming down here, a ton. All of our parasympathetics in the trunk of our body, thorax and abdomen, are going to have vagus innervation here. So we have motor and sensory to a lot of our major organs, as well as some stuff around the ear and pharynx and larynx and stuff like that we'll get into. And so it's our major parasympathetic. So we know all cranial nerves are going to be parasympathetic, but when we get into the body, vagus is our major parasympathetic. So let's start with a deep dive into the glossopharyngeal nerve. So here's my simplified drawing, as well as a couple diagrams. You can see it coming off here and all of its innervations, as well as a look into the ear that we'll get into. And so we've got several different types of innervation, different components that we'll get into. And so our glossopharyngeal nerve comes off the brain and exits the jugular foramen. Now we're going to have two ganglia here. We'll have our superior ganglion, superior, and our inferior ganglion, inferior, named accordingly. And so our superior ganglion is going to have GSA, somatic innervation. And so we can remember that SS, superior somatic. Our inferior will have our other innervations, so GVA, autonomic, and taste. And remember, our GVE will not have synapse yet, so it's our GVA, sensory only. So these are only sensory ganglion. There are no motor synapses here. So somatic, superior, all other sensory is going to be inferior, and then motor does not synapse in these. And so we come down, we're going to give off one of our main branches, which is tympanic. So tympanic, you can imagine that that's going to head towards tympanic membrane or ear region, and that would be correct. So this is going to contain only visceral, so this is only autonomic. And so we come down, our tympanic branch of our glossopharyngeal is going to enter our tympanic canaliculus, And then once it enters this ear region, you can see here, it comes up and it's going to become plexiform. And so this plexiform, the tympanic plexus, is going to be the termination of our GVA afferent fibers. Our GVE efferent fibers, motor, is going to continue on after here, as you can see, and become the lesser petrosal nerve. Lesser petrosal might remind you of our greater petrosal nerve, which we saw in the facial canal. And you can see that, with the facial nerve had the greater petrosal. And so you can see these are running next to each other, so that's why they were named similarly. And they're both going to be at the facial canal hiatus. So that's where you have our greater and lesser petrosal nerve. Continuing the drawing, our lesser petrosal nerve is going to continue and pass through our foramen ovale, which remember is where cranial nerve V3 is going to pass through. And it's going to continue down to eventually join our auriculotemporal branch of V3, auriculotemporal being the branch that wraps around the middle meningeal artery. And so we come down here, and this GVE is going to synapse. So remember, our motor hasn't synapsed yet. It's going to synapse here at this otic ganglion. The otic ganglion is one of the three that is structurally on cranial nerve 5, but is not synapsing cranial nerve 5. So the otic ganglion is structurally on the auriculotemporal branch of cranial nerve V3, but V3 does not synapse here. What does synapse is the GVE components of the glossopharyngeal. And then those are going to ride together to the parotid gland. They'll also be joined by some sympathetic motor components. But so you don't need to remember GVE necessarily. Just think, if we're going to the parotid gland, I'm not controlling the secretions of my parotid gland intentionally. So that's got to be visceral or autonomic. And therefore, it's going to be visceral. And if we know that auriculotemporal is going to have our afferents, then this is going to have our efferents. And so that's the big branch. Let's come back to the main pathway of glossopharyngeal. We'll continue down. So we're still having a lot of components, GSA, GVA, taste, branchiomotor. So a lot of sensory and branchiomotor. We come down, we're going to give off one branch that wraps up here called our auricular branch. Anytime you see auricle, auricular, that means relating to the ear. So this is going to go up and wrap around the ear. And so this is going to have GSA, somatic afferent, somatic sensory, going to some of the skin and regions around the ear. Let's continue down, and we're going to give off another branch, which you can see pretty well here. This is our carotid sinus nerve, or carotid sinus branch. And that's going to come down and innervate the carotid body. And so what this does, our GVA, we're going to go to our pressoreceptors and chemoreceptors of the carotid body, which are right at the diversion of the common carotid, and that's going to be important in regulating things like blood pressure. And so our glossopharyngeal does chemoreceptors and pressoreceptors, and it gives GVA, so that's somatic afferent. Let's continue down. We're going to give off a branchiomotor component called the nerve to the stylopharyngeus. And if you want to take a guess what that's going to innervate, it's going to be the stylopharyngeus muscle. And so that's just branchiomotor, meaning pharyngeal arch derived. So make sure you learn those in the groups of the pharyngeal arches. It's a super good way to categorize them. And then to continue on, our glossopharyngeal nerve is finally going to terminate in the pharyngeal plexus, which you can imagine is going to be a plexus formed at the pharynx. So you can see all these pharyngeal branches innervating GVA and taste, so different autonomic and special components down to the pharynx. So now let's look at the vagus nerve, which you might notice a lot of structural similarity to the glossopharyngeal nerve. They run together and do a lot of similar things. However, the vagus nerve does a lot of novel components. So we'll start off similarly. We come down through the jugular foramen, and we have the exact same superior ganglion and inferior ganglion. These are different ganglia, but they're going to have the same components. It's just different nerves. So remember, we have only sensory, superior somatic, inferior all other sensory, so GVA and taste. And so around this region, we're going to give off a recurrent branch, recurrent meaning it comes back up, and this is going to be our recurrent our recurrent meningeal. Recurrent meaning it comes back up, meningeal meaning it's going to go to innervate the meninges. We continue down, we're going to see we give off a similar branch to the glossopharyngeal. We have our auricular branch, also giving off GSA, and that's going to wrap up to give around innervation around the ear region and the external acoustic meatus and stuff. And so let's continue down. So we know that our vagus is going to go to the body and a whole lot of other stuff. So at this point, we're around the region where the glossopharyngeal stops. So we're also going to give off a branch that goes to the pharynx. So we have our pharyngeal branches from the vagus, exactly the same as from the glossopharyngeal. It's going to go to some different parts of the pharynx, but we're going to give taste, GVA, and some branchiomotor components. And so what you want to know here that I don't have written down is that the pharyngeal branches of the vagus nerve are going to innervate the pharyngeal arch 4 muscles. So that'll be like the pharyngeal constrictors. And so let's go back to our main branch. We continue down as our vagus. Let's also give off a carotid sinus branch, just like our glossopharyngeal. And you can imagine that's going to go to the bifurcation of the common carotid, and it's going to innervate chemoreceptors in the carotid body, just like the glossopharyngeal. However, it does not go to the carotid sinus, so we are not innervating chemo and baroreceptors. We're just doing chemoreceptors, not baroreceptors or pressoreceptors. And so it's called the carotid sinus branch, but it does not actually go to the carotid sinus, just the carotid body. And it's named that because it rides with the glossopharyngeal cranial nerve 9. So make sure you have that distinction clear, not carotid sinus for vagus. So let's continue down, still vagus, vagus, vagus. And now let's give off one branch. So we give off our superior laryngeal branch, and that's going to bifurcate into our external and internal laryngeal. So our superior laryngeal will then bifurcate. Make sure you know that before the bifurcation, it's called superior laryngeal, because if you see these in lab, it could be tagged right here before the bifurcation, but not on the main branch, or it could be tagged on one of these bifurcations. So make sure you know this distinction here. And so our external laryngeal, these are really important ones now. Our external laryngeal will be branchiomotor. What does that mean? Pharyngeal arch innervation. And what does this go to? Fortunately, this only goes to one muscle. So make sure you know external laryngeal is branchiomotor to the cricothyroid muscle. And when you look at the pharyngeal muscles, you'll learn all of the ones that control your voice. And so if you go high-pitched or low-pitched, you'll see a change in that. The cricothyroid, you'll learn a lot more about. That helps your voice become high-pitched. So make sure you always say that as cricothyroid. So remember that, external laryngeal, cricothyroid. And now let's go back. So our internal laryngeal, we're going to have GVA, so autonomic afferent innervation. And this is really important. The internal laryngeal is the one that perforates the thyrohyoid membrane. So in lab, you want to see if you can identify that perforating the thyrohyoid membrane, either on your cadaver or a different cadaver. So it's going to perforate the membrane and innervate the mucosa superior to the true vocal folds. We'll see later down here, inferior, but we have superior to the true vocal folds as the internal laryngeal. And that's also important to know, as you might be able to tell by me underlining and bolding it. So let's go back to our main trunk of the vagus. Continue down, and it will just continue on down GVE to the thorax and give a lot of stuff to the thorax and abdomen. But we have one last branch that's one of the most important ones because people love to ask questions about it. Practicals love to tag it. So make sure you see it in real life. We're going to give off a branch. And this is going to be slightly different whether you're on the right side of the body or the left side of the body. So the branch is going to come down, and it's going to be our recurrent laryngeal branch. Recurrent because it's going to wrap back up. But what's interesting is that on the right side, it's going to wrap around our subclavian artery, whereas on the left side, it's going to wrap around the arch of the aorta. And this is different because remember our big vessels like that are asymmetrical. So it's going to happen at different points, and just also the way you grow. It's going to happen at different places. So make sure you know right from left. Right is subclavian, left is arch of the aorta. And what that means is that the left side, it comes off a little bit lower, a little bit inferior to the right. And so depending on how your cadaver's been dissected, at the Brody School of Medicine, what's typically been done is you go to a certain point to where you only be able to see the subclavian artery. So if a recurrent laryngeal is tagged, it's going to be on the right unless dissection has changed. So that can be a good thing to know. And so what our recurrent laryngeal is going to do, wrap around our subclavian or the aorta and come back up. And that's going to have our GVA and branchiomotor. You can see that here. And once it continues up, it's going to become our inferior laryngeal. So you might have wondered, we have a superior laryngeal, where's the inferior? That's going to be what this becomes. And so what it innervates is our GVA inferior to true vocal folds. So the inferior laryngeal is inferior to true vocal folds. But don't get confused because the internal, not inferior, internal does superior to the true vocal folds. We also have some branchiomotor innervation to all of the muscles of the larynx. So it's not some, it's a lot. So make sure you know inferior laryngeal, which is the continuation of the recurrent laryngeal, provides branchiomotor innervation to all muscles of the larynx. And you'll revisit that when you get to the pharynx and larynx section, except the cricothyroid, of course, because remember, this is our exception. So memorize the trend, or learn the trend, memorize the exception. So it does all of that, as well as some striated muscles of the upper esophagus. Oops, sorry. And so that's all of our main components of the of the glossopharyngeal and vagus nerve. So to end the video, let's look at some clinical correlations. So here are the four ones that I thought most important to look at and to know well is if you have a lesion somewhere on cranial nerve 9, then it's usually going to be grouped with cranial nerve 10 and 11. And so that can make it really difficult to isolate whether the lesion is on cranial nerve 9. And so what you can do is test it with a gag reflex test, which, as you can imagine, is testing if someone has a gag reflex. And you do that by stroking the wall of the pharynx over the palatine tonsils. And if you have a damaged cranial nerve 9, then you have no gag reflex. So make sure you know that. No gag reflex is damaged cranial nerve 9. If you have, and this happens because cranial nerve 10 only does motor of the reflex. It does not do the sensory. So if you had a damaged cranial nerve 10, it would not be able to give the motor, but if you have damaged cranial nerve 9, you won't even get the sensation in the first place. Another important thing to know is otitis media. This is super common with all sorts of infections and stuff, so this is really important to know moving forward. But otitis media is a middle ear infection, and what it can do is cause pain that's relayed by the cranial nerve 9. And I put this here mostly because I want you to get familiar with otitis media. We can also have a cranial nerve 10 pharyngeal branch damage. So vagus pharyngeal branches, damage there is going to lead to difficulty swallowing. And what you can see is if you have a patient open their mouth, at the arch of the soft palate, it'll be drooped on the affected side, just like this picture, and the uvula is going to deviate towards the normal side. And the reason that happens is because you still have all of your muscles functioning here, but these muscles are paralyzed. So since these muscles are functioning just a little bit, it's going to pull just a little bit. These are completely paralyzed, so it'll be real loose to allow it to go towards the normal side. So there are other things that can happen that can cause certain things to go towards the abnormal side. So make sure you know vagus pharyngeal branch damage, difficulty swallowing, uvula will be deviated towards the normal side. This one is blue, bold, and underlined, so I would definitely know that. And finally, cranial nerve 10, recurrent laryngeal damage. So that was pharyngeal branches. This is recurrent laryngeal. You'll see hoarseness and voice loss. This one is also very, very important to know. I would put a bunch of stars on this. Hoarseness and voice loss. And the reason this happens is because you have two vaguses that are innervating both sides of the pharynx. And so you'll get unilateral loss of function. And therefore the opposite fold of your vocal folds will move past midline to compensate and enable phonation or speaking. And so the voice will sound normal, but it'll tire very easily because your muscles are overworking to compensate. And also when you have a thyroidectomy, so if a surgeon is doing a thyroidectomy to remove the thyroid, then you're going to make sure you want to find the recurrent laryngeal, just because you don't want to snip it and have this happen. So if a patient has a thyroidectomy and they start to get hoarseness, voice loss, then you're going to suspect recurrent laryngeal damage.